Welcome, everyone. I apologize in advance for any crying babies or barking dogs you might hear this evening. Welcome to LMC's special program, a clinical practice update series. This being a special webinar outside of our usual spring and fall event. We obviously have everybody who's here today to thank for being able to engage with you on a more regular basis, and in this case, the first of what I hope will be many special webinars. As always, when you enter the room, you should be muted, but just in case that should slip off, please make sure that your line is muted so that during the presentation, we don't get any background noise. As always, during any of our programs, we always leave ample time at the end for plenty of time for questions, both chat or you can even ask your questions. It'll be a 20-minute panel discussion at the end of the evening. Thanks again, everybody, for being here. If you don't know who I am, I'm Alex Abitbol. I'm tonight's chair, and I'm also an endocrinologist and assistant medical director at LMC. I see a lot of familiar names, obviously, on our participant list. For those who don't know what LMC is Canada's largest single specialty group of endocrinologists. Right now, we're 56 endocrinologists in 3 Canadian provinces. We also have the largest team of CDEs that are made up by nurses, dietitians, and our pharmacists. And we care for over 68,000 patients with diabetes across Canada. I believe about 1 in 2 in any patients in Ontario with diabetes is actually followed at an LMC clinic. These are where we're currently located right now. This is in addition to some of our research sites, which engage in both diabetes and clinical research in other specialties. We obviously engage predominantly in diabetes and endocrine research at most of these sites, but they are all general endocrinology and diabetes offices. Currently 13 clinics, and we often get the question when we're going to be filling in the gap with other Canadian cities. Truth is, I don't know, but we obviously hope to expand as we've done so in recent years. This is in the mantra of the CEO, what we hope to be able to offer at each of the 13 clinics. The endocrinology specialty clinic, our diabetes education, clinical and of course investigator initiated research, but more recently having added in a diabetes specialist pharmacy and of course diabetes chiropody and optometry at most of the centers in the hopes of obviously adding them to each of the clinics as the demand gets there. And of course, you know, our vision is to be able to expand the reach of our care beyond those that we're able to see. That's the purposes of programs like this, to be able to obviously help those with diabetes who don't necessarily have the opportunity to come to our office. For those who do, we obviously like to offer a more comprehensive and patient-centric view with all the bells and whistles of the usual publicly funded, short wait times, making it easy to book, and of course employing and engaging with other endocrinologists at different clinics if the need or waiting list should arise. As you know better than I could, Dr. Peter Lynn has been involved with the Clinical Practice Update education series since we restarted it 4 years ago. We would not be able to do it without him, and of course he's involved, you know, every step of the way. Dr. Lynn, whose bio unfortunately will not load right now, so I'll go from memory, is the director of the Primary Care Initiative. He started at the University of Toronto, at first in the Faculty of Science and Engineering, took a pivot, and then went more direct into medicine, and quickly realized that there was a gap between clinical research and education in primary care. He spent the better part of, well, Peter's a young clinician, so let's say 5 to 10 years, although all of you know that it's considerably longer than that, educating and engaging in clinical research. He's won multiple awards in primary care, and of course the co-chair for this evening, Dr. Peter Lynn.
Great, thanks very much, Justin Trudeau. I think your hair is starting to look like his. You're looking like our Prime Minister, which is not a bad thing, I guess. So thank you very much, Alex, for those kind words, and thank you everybody for joining us again. I see a lot of familiar names. You've been at the normal LMC meetings, and this particular meeting was put together because we had such a good response in terms of the lipid section. There were a huge number of questions, so we thought we should do a particular one on this. So next slide, please. So today's agenda, we're going to have Ron Goldenberg, I'll introduce him formally in a second, talking about triglycerides, because we've sort of haven't talked a whole lot about triglycerides until recently. We have some exciting information there. And then we'll have Alex kind of take us through in terms of how do we make sense of all of this stuff for our patients, and then we'll have the panel discussion after that. So please continue to type in the chat box. I'll monitor that. If you happen to put up your hand and I ignore you, it just means I haven't seen your hand put up, but you can certainly type into the chat box your question, and then I will collect all the questions together, and then we'll take care of that at the end. We're going to have a large group, so unmuting the mic may be a possibility, but unfortunately, because so many people are going to be online. Typing it in is probably better. Next slide, please. So basically accreditation, we've got 1.75 credits for this evening. And so you'll be getting that certificate afterwards. Next slide. Mitigating bias, everything that we show you is published. Everything that's a guideline will be flagged as such. Anything that's in the speaker's opinion, they will flag it as being in their opinion. So everything is very well demarcated. Next slide, please. So to our first speaker, Ron Goldenberg, I think everybody knows Ron, trained in Toronto, special interest in diabetes, obesity, lipids, pretty much everything cardiovascular that we've touched. He's been involved in many clinical studies as well as all of the guidelines as well. He's known nationally and internationally for his work, especially in diabetes area. In terms of Diabetes Canada, he's been a sort of a foundation member there, guiding us through. And I guess the key thing with Ron is that he's like an encyclopedia, except he's an understandable encyclopedia. So he takes the information, he knows all the details, but allows us to help understand how the details will help us manage our patients. So with that, I'd like to turn things over to Ron in terms of talking about triglycerides and cardiovascular disease. So Ron.
Great, well, thank you, Peter, and also Alex. Always a pleasure meeting you guys, even though it's virtually, and it's nice to see so many people online this evening, and hopefully you can spend a couple of hours with us and learn a lot of new information. And I'm really excited to present this tonight because this is practice-changing information. And so what I'm going to speak on is the topic of triglycerides and cardiovascular disease. It's time to reduce it, and I'll focus on a trial using Icosapent ethyl to highlight its role in cardiovascular protection in Canada now that this agent has been available really since the beginning of this year. So these are my disclosures. I've received speaking fees, honoraria, consulting fees, and research fees from a number of companies. But I always like to say that all of the honoraria that I received are really in the name of improving the health of our patients with either diabetes or at risk for cardiovascular disease. The objectives of my session are to understand the link between high triglycerides and cardiovascular disease, something that probably we haven't appreciated over the years. We'll then interpret the clinical trial evidence of the REDUCE-IT study. Then we'll hopefully have you understand how to incorporate Icosapent ethyl, and we'll describe what that is, into a vascular protection strategy in your patients with either established cardiovascular disease or diabetes with another risk factor. We'll spend a minute or two helping you to understand the mechanism of benefit of Icosapent ethyl, and we'll touch and review on clinical practice guidelines regarding the use of Icosapent ethyl. Now, I've been in practice for 31 years. I started my own endocrinology practice and joined North York Branson Hospital in 1989. And I'll tell you that over these past 30 years, it's pretty rare that a trial gets done and published that is practice changing, or it really changes the landscape of how we treat our patients. And what I'm going to show you on this slide are the key practice changing trials that over the years really did change the landscape in the realm of cardiovascular protection. So starting on the left of this slide, one of the first practice-changing trials in this area was the 4S study with simvastatin. This was the very first hard outcome trial with a statin showing a major benefit in reducing cardiovascular events, and that paved the way for statins becoming the mainstay of therapy when we're treating from a lipid point of view in patients at high risk for cardiovascular disease. And in the year 2000, the HOPE study came out with ramipril, and that really paved the road ahead for using RAS blockade as a method of vascular protection. And then in 2001 was the first dual antiplatelet hard outcome study called the CURE study. This is with clopidogrel plus aspirin, and that paved the way for a number of approaches for using dual antiplatelet therapy in patients with established coronary artery disease. And then came two diabetes hard outcome trials, the first in 2015 using empagliflozin in the EMPA-REG outcome trial. So this was the first hard outcome trial with an SGLT2 inhibitor for diabetes patients, followed quite closely by the LEADER trial, which was the first GLP-1 receptor agonist study showing a cardiovascular benefit in high-risk diabetes patients. And finally, and more recently in 2017, was the COMPASS trial. This was the first hard outcome trial using a dual pathway inhibition approach with low-dose rivaroxaban plus aspirin. So there you see 6 trials that really have changed the landscape in cardiovascular protection. And what I'm going to talk about tonight is the REDUCE-IT trial, and hopefully you'll agree with me when we get through this that REDUCE-IT can be added to the list of these landmark, landscape-changing trials. So to set the stage for our discussion, I'm going to present a case to you. Her name is Brenda. I'll just summarize Brenda's description, and then we'll go back to Brenda at the end of my presentation. So Brenda is 67 years old. She's overweight. She has some cardiovascular risk factors, including hypertension, dyslipidemia, and a 1 pack per day smoking history. And she has established coronary artery disease, having had a myocardial infarction 2 years ago, at which time she had a stent placed in her left anterior descending coronary artery. You can see her BMI is 31.5, blood pressure modestly elevated. She's normoglycemic. Her GFR is in the moderate renal impairment category. And you can see her lipid profile. I just want to highlight the pretty good LDL cholesterol of 1.3 millimoles per liter. Slightly low HDL cholesterol of 0.9, and an elevated triglyceride level of 3.3 millimoles per liter. Her current therapies include baby aspirin, atorvastatin 40 milligrams, and perindopril 8 milligrams. And obviously each of these 3 agents will independently be providing some vascular protection for this patient. But Brenda is certainly a high-risk secondary prevention patient. She is post-MI, and I think you would all agree that she is still at further risk of cardiovascular events, despite being treated with ASA, statin, and an ACE inhibitor. So the key piece of information with Brenda, besides her cardiovascular disease, were those triglyceride levels of over 3 millimoles per liter. And what I'd like to introduce at this point is the concept, or ask the question, do elevated triglycerides contribute to residual cardiovascular risk in statin-treated patients? And what level of triglyceride level should we be concerned about? So there's a wealth of information on this topic, and I thought I would pare it down to just a couple of slides. This is data from a statin trial called PROVE-IT, done a number of years ago in acute coronary syndrome patients. And in this analysis, they took the PROVE-IT population and looked at patients who achieved a pretty good LDL of less than 1.8 millimoles per liter during the trial. And then they compared on-treatment triglyceride levels of over 2.3 on the left or less than 2.3 on the right of this slide, and basically looked at the risk over 2 years of death, MI, or recurrent acute coronary syndrome. And you can see that those that had triglyceride levels over 2.3 had a significant increased risk of cardiovascular events, despite having a pretty good LDL cholesterol of less than 1.8 millimoles per liter. There's some nice Canadian data on this topic, and this is a slide from the Canhart ASCVD cohort. On the left, the pie chart shows us that roughly 25% of Canadians with established atherosclerotic cardiovascular disease and a good LDL cholesterol, defined here as less than 2.6, because this is kind of older data. Despite the pretty good LDL, 25% of these patients had triglyceride levels over 1.5 millimoles per liter. And then if you look on the right of this slide, you can see that as triglycerides hit 1.5 millimoles per liter or higher, shown over here and moving upwards for triglycerides, there is an increasing risk of cardiovascular outcomes. So what this tells us that even if you think you have a pretty good LDL, if you have a high-risk patients with triglyceride levels over 1.5, they still have a significant residual risk or an increased risk of cardiovascular events. So obviously the next question is, can we reduce cardiovascular events or residual risk in these high-risk patients with hypertriglyceridemia, but a controlled LDL cholesterol? So here we're thinking of the patients who you already have on a statin. Maybe you have them on a statin plus ezetimibe, or maybe even you have them on a statin plus ezetimibe and a PCSK9 inhibitor. Hang on, something just popped up on my slide here. Okay, that's fixed. And so now I'm going to discuss the data prior to reduce it if we can lower risk in these high triglycerides controlled LDL cholesterol patients. And so this is just a summary slide of some key triglyceride lowering trials and their effect on cardiovascular outcomes. So the top panel is what happened to triglyceride levels during these individual trials, control patients in red, treatment group in the light blue, and the bottom panel is the primary cardiovascular endpoint in these trials. So these three trials on the left are fibrate trials. You can see in the VA HIT study with an old fibrate called gemfibrozol, there was not just a reduction in triglycerides, but there was a risk reduction. The problem with the VA HIT trial is this was in the pre-statin era. So these patients were not being treated with statins. You can see in the FIELD trial and in the ACCORD lipid trial using fenofibrate, despite triglyceride lowering, there was no overall cardiovascular benefit in these trials. And it's important to highlight that in the ACCORD lipid trial, this was fenofibrate added on to statin compared to statin alone. So the fibrate trials in the statin era have been quite disappointing, although I will say we are awaiting a new trial called the PROMINENT trial with a fibrate not available yet in Canada called pemafibrate, because this is a trial of patients on statin with high triglycerides to see the benefit of adding a fibrate. Then the trials with niacin have been disappointing. There's the AIM-HIGH trial and the HPS2 THRIVE trial. Again, no significant reduction in cardiovascular events. And then we do have some data with omega-3 fatty acids. The Gissi Provenzioni study did show a small but statistically significant risk reduction with omega-3 fatty acids. But again, this was in the pre-statin era. But there was the suggestion from a Japanese trial in 2007 using a pure EPA form of omega-3 fatty acid or icosapentanoic acid, that there may be a significant risk reduction with an omega-3 EPA fatty acid. This study, however, was just done in Japan and may not be extrapolated to further populations until further data, and that's why the Reduce-It trial that I'm going to show you is so important. So can we truly reduce residual risk with icosapent ethyl? So icosapent ethyl is in fact a highly purified and stable ethyl ester of icosapentanoic acid, or EPA, which is one of the common omega-3 fatty acids that you all know, the other one being DHA. And so this agent was recently approved in Canada and launched in January of this year. It is only available as a prescription, and it's marketed under the trade name of Vasepa, V-A-S-C-E-P-A. And so before I discuss the Reduce-It trial, I just want to review with you very briefly of what would be the rationale for the use of a highly purified EPA. Well, first of all, and highlighted on the diagram on the right of this slide, EPA and DHA, or docosahexaenoic acid, have really different properties and distinct membrane locations. And so what we have learned is that purified EPA, or icosapent ethyl, has been shown to have antioxidant and anti-inflammatory effects, which should reduce the atherosclerotic process, whereas DHA has been shown consistently to be associated with a modest LDL elevation, which you all know cannot be good for atherosclerosis, while EPA is in fact LDL cholesterol neutral. Now, traditionally, sources of these omega-3 fatty acids have included dietary intake of fish or seafood. Some of our patients over the years have taken omega-3 fatty acid supplements. We'll talk about how those can differ from prescription grade EPA a little bit later. And contemporary randomized trials using mixtures of EPA and DHA, which are essentially the things our patients get when they buy over-the-counter omega-3 fatty acids. Individual trials like Ascend, Vital, and Strength, which is not yet published, but we have a press release, using doses from 1 to 4 grams of these mixtures per day on top of statin therapy, have been neutral or disappointing. And even meta-analyses of these EPA-DHA mixture randomized trials have been disappointing. Yet, as I mentioned earlier, there's perhaps a suggestion that pure EPA rather than mixtures of EPA-DHA might provide a cardiovascular benefit, and we learned that from the Japanese JELIS trial, where they used 1.8 grams plus a statin to show a cardiovascular benefit. We also know that icosapent ethyl, which was approved in the United States a number of years ago, is pretty darn good at lowering triglycerides, where they fell by almost 25% in statin-treated patients who had modestly elevated triglycerides in the 2.3 to 5.6 range. So I use that as an introduction to the Reduce-It trial. This slide shows the design of this landmark paradigm-changing trial. The key inclusion criteria are highlighted on the top left. They took statin-treated adults that either had established cardiovascular disease, which represented about 70% of the patients, or diabetes with another traditional cardiovascular risk factor. To get in, you had to have triglycerides between 1.7 to 5.6, but because triglycerides can vary quite a bit, they allowed for a bit of variance. So you could actually get into the REDUCE-IT trial with triglycerides between 1.5 and 5.6 millimoles per liter. They also wanted patients with well-controlled LDL cholesterol levels on statin therapy. And so the LDL was between 1 to 2.6 to get into this trial. After they enrolled over 8,000 patients, about 59% of the patients had diabetes. About half of those were secondary prevention, and the other half were primary prevention. So that was diabetes with another risk factor, but no established cardiovascular disease. So these patients were simply randomized to Icosapent Ethyl, 2 grams twice daily with food versus placebo. It was an event-driven trial. As it turned out, the median duration was just less than 5 years, and the primary endpoint was a composite of cardiovascular death, MI, stroke, revascularization, or unstable angina requiring hospitalization. So before I show you the cardiovascular results, I just want to briefly comment on the effect on biomarkers after about 1 year in the study. And you can see triglycerides started off at baseline median of 2.4 millimoles per liter, and they fell by about 20% versus placebo, which is what you would expect based on previous data with Icosapent Ethyl. LDL cholesterol was modestly reduced at 6.6%, but importantly not increased. CRP was reduced by 40%, but the most robust change in biomarkers, understanding that we were giving patients pure EPA, is that it rose from baseline by almost 400%. So obviously, if you give patients EPA, and as long as they adhere to the therapy, you would expect a big rise in their EPA blood levels, and that's what they showed in this biomarker analysis. So the next slide is the primary endpoint, and these are the Kaplan-Meier curves, placebo in red, Icosapent Ethyl in blue. Here you can see a relative risk reduction of 25%, an absolute risk reduction of 4.8%, quite an impressive number needed to treat over 4.9 years of only 21, and a very robust p-value of 0.00000001. So some people say when they look at first trials that show such a result that could this be a fluke? And the answer is, with a p-value like this, there is no way that this result can be a statistical fluke. This is statistically robust data. Note that, like other trials that target atherosclerotic cardiovascular outcomes, it takes about 1 year to show a benefit because it takes a bit of time to stabilize the plaque and reduce atherosclerotic events. So they looked at various predefined subgroups for this primary endpoint, and basically it didn't matter whether you were a secondary or primary prevention patient, whether you had diabetes or did not have diabetes, whether you had triglyceride levels less than or over 1.7, what triglyceride tertile you fell in at baseline, or whether or not you achieved a triglyceride level of less than 1.7 or greater than 1.7. The effect on the primary endpoint was essentially the same across all of these subgroups, with no significant p-value for interaction. They've also analyzed what can explain this robust 25% relative risk reduction, and it's actually not explained by that 20% reduction in triglycerides. In fact, in the mediation analysis that was done, it was shown that the EPA levels largely correlate the best with the reduction in the primary endpoint. So it's raising EPA that explains the cardiovascular benefit, not lowering the triglycerides. even though to get into this trial, remember, you had to have triglycerides over 1.5 millimoles per liter. So there's a typical MACE endpoint, which was the key secondary endpoint of CV death, MI, and stroke. Here, essentially, you see the same results that you saw with the primary endpoint, with a very robust number needed to treat of 28 and a nice p-value. And similar to the subgroup analysis for the primary endpoint, it didn't matter whether you were primary or secondary prevention, whether or not you had diabetes, whether or not you had higher triglycerides at baseline, or whether you achieved or did not achieve a lower triglyceride level. And just like the primary endpoint, the factor that explained this benefit on the key secondary endpoint was mainly raising blood EPA levels and not explained by lowering triglycerides. And then there's a whole slew of other outcomes listed in the hierarchical testing strategy that was done in the trial. The green box on the left lists those various outcomes, and the green box on the right shows you the significant results for these various outcomes. So basically, in summary, it's not just the primary and secondary composite outcomes that were reduced, but there was a 25% reduction in myocardial infarction, a significant reduction in revascularization, including CABG. And I will say that this is the only non-LDL cholesterol intervention that has been shown to reduce coronary artery bypass surgery in a large clinical trial. There was a reduction in cardiovascular death, a reduction in hospitalization for unstable angina, and a reduction in fatal or non-fatal stroke. You can see at the very bottom that total mortality did not quite reach statistical significance, but one might speculate that if they followed patients for a little longer and perhaps had more deaths arise, that even that possibly might become statistically significant. But very robust results for not just composite outcomes, but individual outcomes like MI, stroke, revascularization, unstable angina, and even cardiovascular death. Were there side effects? So the two most common side effects that I'll discuss were bleeding and atrial fibrillation. You can see at the top of the table here that when they looked at any bleeding event, 11.8% on Icosapent Ethyl had a bleeding event versus 9.9% on placebo. That was significant difference, but the absolute difference is rather small. Fortunately, there was no increase in serious bleeding-related disorders, including GI bleeding or CNS bleeding. There were absolutely zero fatal bleeding events in either group, which is encouraging considering there were over 8,000 patients in this study. And there was no signal for adjudicated hemorrhagic stroke, which is something we're quite fearful of. And bleeding, however, was somewhat greater in patients who were receiving other antithrombotic medications with Icosapent Ethyl, such as aspirin, clopidogrel, or warfarin, but the difference was rather small. So it was 13% of bleeding events with Icosapent Ethyl and other antithrombotics versus 11% on placebo. But there is a caution and mention in the product monograph about this issue. So there's no contraindication for giving antithrombotics with Icosapent Ethyl, but just be aware that there's a slight increased risk of bleeding with these patients. Atrial fibrillation, which is adjudicated, was increased 3.1% on Icosapent Ethyl versus 2.1% on placebo. It's a significant increase. It's an absolute risk increase of only 1%. And I just want to highlight and remind you that despite an increase in atrial fibrillation, there's a significant reduction in stroke with Icosapent Ethyl, suggesting that even though slightly more patients develop atrial fibrillation, they still seem to be protected from stroke with Icosapent Ethyl. So I showed you this slide earlier, and the only difference is I added in the Reduce-It trial in the red box on the right. And basically what we now can say is that when you look at triglyceride-lowering trials, probably the most robust data is now out of the Reduce-It trial, where there was a 20% reduction in triglycerides, which, by the way, didn't explain the overall cardiovascular benefit, which was this 25% risk reduction, the primary outcome shown on the bottom right of this slide. So why would it work? So if it's not from lowering triglycerides, how can raising blood EPA levels by like 400% lead to this major reduction in cardiovascular events? And a lot of work on this topic has been done by Preston Mason in the US and his colleagues. And the top line summary of this is that pure EPA seems to improve endothelial dysfunction or lessen endothelial dysfunction. It reduces oxidative stress. It seems to have anti-inflammatory effects and reduces plaque or atherosclerotic plaque growth. And it seems to also have an impact on stabilizing the atherosclerotic plaque. And each of these three major categories shown on this slide should in fact lead to a reduction in atherosclerotic events. So, you know, various guidelines have looked at the Reduce-It trial and made pretty compelling recommendations for integrating Icosapent Ethyl into a CV risk reduction strategy. So the American Diabetes Association in January of this year published their updated guidelines. I want to highlight the text in red on this slide, and that is that if you take diabetes patients with ASCVD or diabetes patients with just other cardiac risk factors who are already on a statin with a controlled LDL, but triglycerides between 1.5 to 5.6, which was the entry criteria to get into Reduce-It, the addition of Icosapent Ethyl should be considered to reduce cardiovascular risk, and that's a grade A recommendation. They also note on the next bullet down that data are lacking with other omega-3 fatty acids, and the results of the Reduce-It trial should not be extrapolated to other products. So if your patient asks, can't I just go buy an omega-3 supplement at the pharmacy or the health food store? Well, the answer is no, because you're not going to get any proven cardiovascular benefit with those products. And because they're generally mixtures of EPA, DHA, the trials actually have been rather disappointing with those mixtures. There's also a specific mention at the bottom of this slide of combinations of statin plus fibrate and statin plus niacin, and they particularly call out these combinations as being not recommended with a grade A recommendation, largely because of disappointing outcome trials, and I summarized those on the earlier slide about triglyceride-lowering trials. The European Society of Cardiology and the European Atherosclerosis Society updated their guidelines in 2019. I just want to highlight the red box, and that is in high-risk patients with triglyceride levels, again, between 1.5 to 5.6, despite statin therapy, and omega-3 fatty acids such as Icosapent Ethyl, 2 grams BID, should be considered in combination with a statin. So what does the product monograph for Vascepa in Canada state about its indication? The wording is shown in this slide. And just to highlight, this agent is indicated to reduce the risk of cardiovascular events. In brackets is basically the primary outcome of the Reduce-It trial in statin-treated patients with elevated triglycerides. They actually don't define elevated triglycerides in the indication statement in the product monograph, but I'll remind you that to get into Reduce-It, you had triglycerides of 1.5 millimoles per liter or higher. And then they specifically mentioned who are these patients who would benefit. It's those with established cardiovascular disease or diabetes and another cardiovascular risk factor, because these were the patients that were studied in the Reduce-IT study. The dosage of this agent for CV protection is 2 1-gram capsules twice a day with food, so 2 capsules with breakfast and 2 capsules with supper. Now, I mentioned earlier that I was going to touch on why can't your patient just go get a non-prescription fish oil capsule and use this and expect to get similar results that you would get with prescription Icosapent Ethyl. And the rationale for not recommending these non-prescription therapies is summarized on this slide: common fish oil on the left and Icosapent Ethyl on the right. So first of all, most fish oil supplements that your patients will buy over the counter contain DHA as well as EPA, and I'll remind you that DHA can raise LDL cholesterol. However, IPE or pure EPA does not have any DHA and does not raise LDL. In fact, in Reduce-IT, it fell by about 6 to 7%. These common fish oil preparations that our patients take are mixtures of a whole bunch of fatty acids. So these include impurities such as saturated fat, cholesterol, and oxidation products. And many believe that these impurities may increase the risk of cardiovascular disease. Whereas if you prescribe IPE or Vascepa, you know you're getting pure EPA without any impurities. Furthermore, as I've mentioned, Vascepa is Health Canada approved for CV risk reduction, whereas none of the common fish oils are approved for CV event reduction. So what if your patient asks, well, you took 4 grams of EPA in the Reduce-IT trial. What if I make sure I take enough common fish oil and get 4 grams of EPA? And the answer is, well, to do that, you would have to take anywhere from about 10 to 40 capsules of the commonly used preparation. So that's an incredible pill burden. And then also you're getting the added DHA and the added impurities that may not provide a benefit and may, in fact, may counteract some of the benefit of the EPA. Also, patients that take common fish oils often complain of a fishy taste or fishy burps, and that was not shown in clinical trials with Vascepa or IPE. So finally, how can we take the Reduce-IT trial and understand it in the context of residual risk reduction for all the things we already do in patients with known cardiovascular disease? And so the traditional approach has been high-intensity statin plus aspirin plus an ACE or an ARB for our patients with known cardiovascular disease. And then on the bottom part of the slide are all the current things we can do to target further residual risk. So on the far left is you can further lower LDL with ezetimibe or a PCSK9 inhibitor. Moving to the right, beyond the red box, I'll touch on that in a minute. If you have diabetes, we can add a GLP-1 or an SGLT2 for these high-risk patients to further reduce risk. If you add low-dose rivaroxaban, 2.5 BID to aspirin from the COMPASS trial, or you give dual antiplatelet therapy, you can further reduce thrombotic risk. And although inflammatory intervention has not yet gone mainstream, there is some clinical data with canakinumab and colchicine suggesting that you can further reduce risk if you have a high CRP. But now in the red box, I want to highlight that if you have a patient with cardiovascular disease or in fact diabetes with another risk factor, you can further target residual risk in those patients with triglycerides over 1.5 by adding Icosapent Ethyl 2 grams BID into their cocktail of anti-cardiovascular event medications. And so I showed you this slide earlier of the 6 practice-changing, really paradigm-changing trials that have paved the way for further CV risk reduction in our patients. And hopefully you'll agree that the REDUCE-IT trial that was published in 2019 can be added to this list of landmark trials. So I'll just finish up and go back to our case, Brenda, to put this in a clinical context. So she was 67 years old with documented coronary artery disease and other cardiovascular risk factors. The main lab parameter of concern was the triglyceride level of 3.3, despite a nice LDL cholesterol of 1.3. And we asked the question is, could we further reduce residual risk beyond her aspirin, statin, and ACE inhibitor, understanding that she's a high-risk secondary prevention patient. So you can see where this is leading now is that based on the REDUCE-IT trial that I showed you, Brenda meets the criteria for REDUCE-IT. She has documented cardiovascular disease. Her triglycerides are well above 1.5 millimoles per liter. And therefore, it would behoove us to recommend to Brenda to start Icosapent, Ethyl, or Vasipa 2 grams twice daily with food to give her a further 25% relative risk reduction in cardiovascular events, a number needed to treat of only about 20 with really excellent tolerability on top of her other cocktail of medications. And so just to summarize what I've shown you tonight is that hypertriglyceridemia does seem to be associated with residual risk in our statin-treated patients, that Icosapent ethyl 2 grams BID or 4 grams BID, currently available as a highly purified prescription form of EPA in high-risk patients with elevated triglycerides, not only reduced a primary composite outcome of 25%, but reduced CV death, myocardial infarction, stroke, as well as revascularization and unstable angina. There was consistent efficacy across various subgroups, including whether or not you had higher baseline triglycerides, whether or not you had higher or lower achieved triglycerides, whether or not you were primary or secondary prevention, or whether you had diabetes with another risk factor. And generally it was well tolerated, but we should appreciate the small increase in atrial fibrillation, despite that lower risk of stroke, and a non-statistically significant increase in serious bleeding. So I think I'll stop there and I'll stop sharing my screen and I'll turn it back to Peter Lynn to move forward on the agenda.
Great. Thanks very much, Ron, for taking us from 1996 all the way up in terms of the landmark studies. That was wonderful. And it kind of puts into perspective all the things that we have now adopted. And so now we have new data that says that we should adopt this as well. To move us further, we have Alex Abitbol. You met him as the chairperson of this meeting. I think many of you know him. He was trained in McGill. Thankfully, he came to Toronto. And at LMC, he's the assistant medical director at LMC. And when he came back, that's when all the education started to come back again. Because I think all of us remember LMC as having education in the beginning, and then there was this big gap. And then now Alex has taken on that mantle. Not only is he practicing and seeing endocrinology patients for all of us, but he's won many awards in terms of education while he was in training. And now he's doing the same thing in terms of our CME events, both going pre-COVID with the live events and now going virtual and taking us into this area. So I want to thank Alex for resurrecting this good education forum for us. And I'll turn things over to Alex to take us into some of the practical issues around the triglyceride issues.
Thanks, Peter. It's always a real challenge to have to follow Ron Goldenberg. I mean, he's such a great speaker, but actually I'll take advantage of this as, you know, much of the information that I'll be presenting tonight, Ron has largely covered. So I get to get a little bit more practical with it. And while understanding the data doesn't always translate into the implementation of new practice guidelines, I think that the conversation with the patients needs to change a little bit. And so I'll try to pepper in some tips here, at least based on, as you just heard, fairly the important and landmark findings that was otherwise not really considered in a class or even a direction of triglyceride lowering, if that is what we're trying to achieve here, or whether maybe it's something with Icosapent, Ethyl that differentiates it. So today we'll talk about making sense of this new evidence, and these are my disclosures. Like Ron, I've had the pleasure of working for most of the companies that have anything to do with diabetes. And here are our learning objectives. Like Ron, we'll touch on very, very briefly some of the biochemistry that goes into triglycerides and how that translates into atherosclerotic risk, really trying to translate it into the conversation that you'll be having with your patients. We'll touch again also on residual risk and why this is an important topic, despite your patients telling you that they already take too many medications, and of course, practical considerations for both the patients that you just heard about, but also different kinds of patients. So Ron, I stole the slide from you. I hope you don't mind. Brenda was the patient that, of course, you just heard about. In someone like Brenda, you can generally see that having had an MI 2 years ago, having hardware in one of her coronary arteries, she has that established cardiovascular disease, or the secondary prevention or high-risk secondary prevention patient. Not only does she have an MI, she also has ongoing risk factors like smoking. And so in Brenda's case, having the conversation seems a little bit more overt. You've seen the number needed to treat that Ron has shown you. Most people, if they see somebody with established disease as a smoker, since we saw the 4S trial, we're generally considering statins. But the conversation tends to be a bit easier in somebody with disease because the numbers and obviously the relative risk reductions are a lot greater in those with established disease. You can see there's plenty to work on with Brenda, though. She's also overweight. She has mentioned she's a smoker. She has some systolic hypertension here, or maybe you just scared her in the waiting room. Her HDL is a little bit below target, and we'll keep an eye on that non-HDL as it wasn't touched on in the first presentation, but I'll share some insight as well as we move forward. And she takes the usual medications that someone who's more than a year post-MI. So we'll come back to Brenda. But as Ron echoed already, 25% relative risk reduction with a 4.5% absolute risk reduction is obviously a substantial finding when we're dealing with IPE versus placebo. But these were a high-risk group of secondary prevention patients. No more to mention there. When we talk about the patient that's far more common in our practice, and certainly far more common in my practice, Carl has type 2 diabetes and no established cardiovascular disease. He does mention a very strong family history of cardiovascular disease. He has a LDL of 2.4. A1C is slightly above target. You can see his triglycerides are also elevated at 4.1, and he is on some of the usual medications you might find somebody with diabetes and risk factors on. He's on metformin. He's also on dapagliflozin or Forxiga. He takes perindopril or Poversil, and he's also on rosuvastatin or Crestor at one of the lower doses. So in this case, at least what many of us largely accept to be the components of about 80 or 75 to 80% of any diabetes practice is somebody who does not have established disease. It's a little bit different if you look at family practices versus cardiology practices, as generally speaking, you'll find more secondary prevention patients with the specialist. But 4 out of 5 of our patients tend to not fit into that Brenda category that Ron just presented about. So let's see where that fits. In general, when the slide that Ron showed you tried to separate whether there was any difference in the REDUCE-IT trial with Icosapent Ethyl, whether you had established disease or whether you didn't, you can see that obviously those with disease had more to benefit. Their hazard ratios, their absolute risk reduction were greater. You need to treat less patients, only 23 in order to actually get there. And you can see for the primary prevention, less of a only a 19% relative risk reduction with a number needed to treat of 63. But when you're looking at a slide like this, well, the attention should really focus on the p-value for interaction, since this is hierarchical sub-analysis. And that means that if they achieve their primary endpoint, what they essentially do is they test the secondary endpoints to see if there's any difference between these two groups of patients. And since you're seeing a non-significant p-value for interaction, then what you can conclude is that having established disease versus not having established disease, at least for this groups of high-risk patients, didn't actually change whether or not they were actually treated with the group, as both benefited from this. Now, this is a slide presented in most of the iterations of the Diabetes Canada guidelines, thinking, of course, of our patients with type 2 diabetes. And this is where that nuanced phrase that you tend to see in clinical practice of your patient that has no diabetes, but who has no diabetes versus somebody with established disease actually has the same risk in the women's heart study for having the event of cardiovascular disease. So if you have established disease and no diabetes versus diabetes and no established disease, you can see that your relative risk is about the same here at 8.61 and 8.66. And that's where the idea of diabetes as being a coronary risk equivalent actually comes from. And so the question mark, at least if we're talking now about the CEPA and triglyceride lowering, is should we be applying the principles any different to those with established disease versus those that have diabetes and risk factors? Now we'll pause and we'll shift a little bit to everybody's favorite topic, which is triglyceride metabolism. So first, why are triglycerides even important? Well, as you saw in the 80s and 90s, it seemed like we found that silver bullet with the LDL particle. It made sense that lowering LDL translated into cardiovascular risk reduction, but there tended to be ongoing patients who, despite having very low or relatively low LDL, they still had ongoing disease and recurrent events. Here are some of the reasons, and obviously we've highlighted the one of reference for tonight, which is triglycerides, but there are many that are probably not even on this list. We'll talk a little bit about triglycerides and oxidation and inflammation and certainly the impact of diabetes. The others, probably best served for another discussion, but the question marks that remain around hypertension, Lp(a), thrombosis, whether there's other factors that contribute to endothelial dysfunction, as well as others that you see on this list, certainly have something to do with the pathophysiology of this residual risk. Ron already covered this, but the difference between looking at an LDL graph and looking at a triglyceride graph is that as your LDL increases and increases and increases, and you get into a genetic LDL or a genetic familial hypercholesterolemia, that risk continues to escalate with it. Why triglycerides, if you will, are a little less sexy are because there tends to be a bit of a plateau. When you have triglycerides less than 1.5, you can see that there's a linear increase in risk like you see with LDL particles, but after the triglycerides of 1.5, you don't tend to see that difference anymore remain. So here's a little bit of that cascade that's currently being looked at right now for triglycerides. You can see here that that LDL particle under the influence of smoking or other oxidative pathways forms a foam cell. That foam cell gets under the endothelium and then contributes to this plaque as it's delivered into it by these lipid-laden macrophages. Lots of different other pathophysiological processes. You can see the cell signaling and the conversion of VLDL to LDL particles. Certainly Dr. Hegley would probably put it a lot better than I could, but we're still discovering a lot of the different cytokines and factors that contribute to this process. Now, as for the triglyceride metabolism and the pathway here, you can see here that your triglycerides are mostly packaged into different particles. The chylomicron particles come from your intestines. They tend to be predominantly triglyceride rich, and what your liver actually makes, as I'll show you on the next slide, is not LDL particles. People tend to think of the liver as being a producer of LDL particles. The liver actually only clears these LDL particles. The liver actually makes VLDL particles, and through lipoprotein lipase, which is the main enzyme that digests triglycerides, it eventually gets converted into LDL, and much of obviously what we've understood about LDL and the pathophysiology of plaque progression. Your triglyceride-rich particles, as you can see here, are your VLDL and your chylomicron particles, and you can see that that component of the non-HDL, which is essentially any particle that has an ApoB on it, includes LDL and these chylomicron particles. HDL, of course, having its own ApoA particle, tends to be the housekeeping lipoprotein at clearing away some of the cholesterol that's in plaque. So just remember that if you're looking at the top of this slide on the right, that these particles are not uniformly made of either triglycerides or cholesterol. They just have different components depending on where they are in the hydrolysis or the cholesterol metabolism, if you will, as they lose triglycerides over time as tissues are fed and eventually get converted into LDL particles, which are more cholesterol rich before being uptaken in the liver. I promise there won't be much more on the biology of triglycerides. In my practice, though, when I tend to see patients with high triglycerides, and of course, because I work in an endocrinology office, we tend to see very, very high triglycerides. We see triglycerides sometimes in the 20s, in the 40s. The highest triglyceride I had ever seen was actually 126. And we realized it while on the ward because we had to draw his blood ourselves. And as we sat there, because maybe we're not as quick drawing blood as maybe some of the nurses that could be in attendance tonight because we were residents and we don't draw that much blood. But because it took us a bit more time, we noticed that while the blood was sitting on the windowsill, about 60% of it turned this milky yellow-white color. And we knew that we were in for a treat when we saw his triglyceride level. So usually it takes a couple different hits. Usually somebody who does not have a genetic predisposition to triglyceride, who is not a very good eater, he drinks lots of alcohol, might have diabetes, would tend to land into that mild or moderate range. Similarly, somebody with maybe a genetic predisposition, and the genes implicated are really under investigations, and certainly we haven't identified all of them yet, that they'll have a mild to moderately elevated triglycerides. If they have one of the more inherited hypertriglyceridemia syndromes, then in that case, they might have very high triglycerides. But for those with the more typical genetics, then that combined with any of these risk factors that you see on the screen is usually what gets you into the severely hypertriglyceridemic range, where you would typically refer to your endocrinologist. But for the vast majority of the other patients that either have a genetic predisposition or some of these risk factors, you'll usually find your patients in that category where you're not quite considering a fibrate, but they may actually benefit from IPE. And here is that role of lipoprotein lipase that we talked about. You can see here that the triglyceride-rich chylomicron, that this clunky big particle, comes across the lipoprotein lipase, which is essentially an enzyme bound to the membrane of this endothelial cell. And as the triglycerides leave the particle and enter the tissue, they become chylomicron remnants and IDLs, which are triglyceride, which have less triglycerides in them. So what happens when you have a loss of function in your lipoprotein lipase, the most classic form being a complete knockout mutation of this enzyme, which would lead to the disease called familial hypertriglyceridemia. Well, as you might guess, you have higher triglycerides, but also, as seen in most of these patients born with these reduced LPL activities, they have a higher risk of coronary artery disease, as I will show you. Similarly, if you have increased LDL activity, as there are some gene mutations that actually result in a gain of function, or as you can see here from some of these or some of these inhibitor enzymes, that actually a loss of function there leads to the promotion of LPL, that you get less triglycerides, but also a reduced risk of coronary artery disease. So why haven't we been talking about this? You know, if we've been talking about the 4S study since Dr. Abitbol was 7 years old, then why can't we actually get to any meaningful recommendation for triglycerides? Well, not only had it to do with that curve that you can see that linear relationship like we saw in LDL wasn't there, but thus far, as Dr. Goldenberg showed you, most of the cardiovascular outcome trials with any of the usual triglyceride-lowering agents, including even some recent ones like Strength, didn't translate into that same benefit that you're seeing in the REDUCE-IT trial. Ron also already touched on this, but what is it about these fish oils and why my patients who actually decline going on this medication, as obviously cost and coverage tend to improve, we'll see if that changes. But generally speaking, they tell me, well, you know, I'm already taking a fish oil and I've been doing so for the last 30 years. They're usually picking them up at any of the drugstores, Shoppers, or maybe their natural doctor. And when you talk about commercial fish oils, well, you're actually talking about a mixture of omega-3 and omega-6. And we'll go more into that on the next slide. What is omega-3 made of? Well, as Ron showed you, DHEA and EPA, DHEA being implicated in maybe some negative effects with a higher LDL, and EPA some of that beneficial effects that we'll show you on the next slide. EPA essentially is that driving class of fish oil, if you will, that makes the difference. And IPE is essentially a new chemical entity, which is a unique form of EPA that was used in the Reduce-It trial. This slide I'm not going to belabor, but as Ron mentioned, you have certain fish oils that are actually pro-inflammatory or would actually contribute to atherosclerotic disease, and omega-3 generally considered anti-inflammatory, much based on the EPA that's in it. And of course, they have looked at since 2011 the change in C-reactive protein. So for at least those that rely on inflammatory markers as being notable drivers of potentially cardiovascular disease, you can see here that when looked at independently, taking omega-3 fatty acids reduced a high sensitivity CRP. This we also already talked about, but EPA and DHEA are obviously very important because they make up most of our cell membranes, and this is where much of the discussion about whether or not lipid lowering has any implication with dementia. There isn't much, evidence or anything except for anecdotal reports, but this is where a lot of that comes from. Is there a level of lipids in your blood that you can reach where it's so low, as we would have postulated with PCSK9 inhibitors, that maybe it actually becomes hazardous? That has not been seen, and we now have some pretty good data even in the stronger lipid lowering trials, but you can see here that not only is there a component of cholesterol, but also a component of DHEA and EPA in most of the linings of our blood vessels and our brain. So what are those beneficial effects of EPA? Well, besides what we've already mentioned, you can see that when you get at that pathophysiological process that was shown previously, these are some of the demonstrated benefits that are published in atherosclerosis since 2015. Much of it obviously in vitro, waiting to see if there's any actual clinical data or human data that can demonstrate something like this on a more reproducible basis, but these tend to be at least some of the postulated mechanisms thus far. And so when you're actually comparing, well, what it is that you're taking, if your patients tell you they're taking those commercial fish oils, well, they're probably taking something that has about 21% of the beneficial compound. The other 79%, who knows? It could be hazardous, like the 9% DHEA. It could be, as well, Dr. Hegley would point out, boiled soup, as that's not really what you're looking for. What you're looking for is Icosapent ethyl, and essentially that's a pharmaceutical grade of 96% plus EPA ethyl esters. And so you're not actually comparing two of the same compounds. You could make an argument, if you want to analogize it, that this would be equivalent to somebody taking some of the commercial brands of calcium and vitamin D if they're vitamin D deficient and would actually benefit much more from the larger doses of vitamin D, which we now give. I think Ron put it best, but I think this was the slide he was alluding to. If you do want to take enough of the commercial omega-3 fatty acids to add up to what 4 tablets or what 4 grams of IPE looks like, well, it looks like either this hand in the middle showing you some of the commercial EPA dietary supplements, or if you want a natural food source from fish, which is definitely going to be very fishy tasting, we'll let you count, but that's a lot of pills. And now the question that Ron has already brought up, which is it something about IPE, or is it actually triglyceride reduction, or is it both that explains some of this benefit that we're talking about this evening? So first things first, IPE has demonstrated its ability to lower triglycerides, whether you're in the moderate to severe range, whether you're in the severe range, whether you're on statins or not. You can see here that the molecule certainly does lower triglycerides. What was interesting is that in the Reduce-It trial, looking first at baseline fasting triglycerides, whether you had triglycerides above 2.3 or less than 2.3, you can see that both derived a significant benefit and there was a non-significant p-value for interaction. You want to go a little lower, whether it was greater than 1.7 or less than 1.7 for the fasting triglycerides at baseline, you can see that that also didn't translate into any p-value for interaction. One thing that has come up, at least for the biochemists on the line who've already observed, that, well, wait a second, you told me that triglyceride lowering had to do, didn't actually translate into the reduction, but that those non-HDL particles did include triglyceride particles. And I remember from my Odyssey and Fourier trial that not only did they look at LDL, but when they looked at non-HDL, the benefit was certainly seen at lowering non-HDL when you have high triglycerides, similar to when you're seeing a lower LDL. So a 13% reduction in non-HDL, maybe that's what explains some of the benefit that we're seeing here. This led to an editorial based on this exact point, and at least from some of the gurus in the field, they felt that this amount of non-HDL reduction, at least as observed in meta-analyses before, should roughly translate into a 5 to 6% relative risk reduction in that 3-point MACE, not a 25% reduction. So the question around whether or not there's some pleiotropic effect of IPE versus its triglyceride lowering is still up for discussion. And as mentioned, some of the usual biomarkers like high sensitivity CRP has been seen before, and a marginal reduction in ApoB, but maybe still significant at 10%, may have also contributed to some of that benefit. What it was certainly not due to, as Ron pointed out, was they also looked at the triglyceride reduction that was achieved at a year. And if you were looking at your primary endpoint, that didn't explain the difference. And if you were looking at any of your key secondary endpoints, whether you achieved the triglycerides of less than 1.69 or whether your triglycerides stayed above 1.69, you derived a similar benefit from IPE as compared to placebo. So what am I going to tell my patients? When I go back to Carl and Carl tells me that he has diabetes and that I now have so much to do with Carl because his A1C is above target and his LDL is still above target and he has a strong family history and there may be other molecules that might be beneficial, but you are staring down a triglyceride of 4.1. The argument here is being, what's the next discussion, if you will, about how Carl can best achieve a reduction in his long-term cardiovascular risk. Because in Carl's case, you might think that somebody with primary prevention is already taking a statin and may not understand the benefit of taking other lipid-lowering medication, since the benefit of statins have been described for the last 30 years. As you might guess, you recommended IPE. Unfortunately, Carl declines additional medication, or perhaps you prescribed it and he wasn't covered, or perhaps he prescribed it and unfortunately didn't take it, which led him, unfortunately, to see you 15 years later. I'm assuming you saw him regularly, and this case is completely made up, but he had his MI 3 years ago now. And since he had his MI 3 years ago, you can see here that with 22 years of diabetes and now with triglycerides of 2.9, he got his LDL under control. His A1C could still use some work, but he's had some therapy added, including sitagliptin over the years and the usual cardiovascular cocktail. But Carl has now become a secondary prevention patient. And so while we commonly debate, and at least the makers of this product, as well as many endocrinologists, will debate whether or not there's a benefit to be seen in primary prevention, especially those with diabetes, or if the benefit is, for now going to rest in secondary prevention based on the data and obviously some of the recommendations that have been made. The question mark remains that obviously for somebody like Carl, well, if we go back to that famous diabetes candidate table, well, he now fits up here, which is generally a category of patients we don't even talk about, but they are at exceedingly high risk of recurrent events. And of course, somebody with diabetes for more than 20 years and somebody with established cardiovascular disease, pill burden being very important in the consideration, but you can see here that the benefits are starting to far outweigh any potential risks. Here's a practical algorithm that was actually adapted from circulation. It should probably be adapted to a certain extent, but you can see here that the point will generally still carry forward. Usually, and why the recommendation has now been made that you can get away with doing non-fasting lipid panels is because the vast majority, even with some of these risk factors, will still have a non-fasting triglyceride less than 2.6. So if they do, then if they're less than 1.13, you can pat them on the back. If they're less than 1.69, then obviously you can ask them to strive a little bit better with diet and exercise, but it's truly the cases that are in either the 1.69 to 2.25 or the 2.26 to 5.63 category that would typically benefit from either dietary recommendations, weight loss, changes in dietary fat content, and usually aerobic activity is recommended. They forgot one here, but certainly discussions around alcohol and reducing alcohol consumption would equally be important. Those with very high triglycerides, whether you're looking at 5.64 as being your cutoff or whether or not you're using 5.5 as is mentioned on UpToDate, those would be the ones that historically got a fibrate, not to reduce their cardiovascular risk, but actually to reduce the risk of spontaneous pancreatitis. If their non-fasting triglyceride is above 2.6, this is usually where we would recommend a fasting lipid panel and then similar considerations based on the results. So this might be a helpful slide for maintaining maybe your wishes to do non-fasting lipid panels, even though I can tell you I don't generally do them. But for those that are seeing patients with less diabetes and less of these risk factors, it might be reasonable to adopt this approach. And of course, for those that fit into the category of patients we just presented, that usually when their LDL starts off above target and you prescribe high-intensity statin, for those that still have an LDL that's above target, you might consider additional LDL reduction, whether you're using Improve-It and adding Residual, whether you're using a PCSK9 inhibitor. That typically depends on the amount of triglyceride reduction you're looking for, LDL reduction you're looking for, but also the background of your patient. If their LDL is at target, and we'll see what the CCS has to say about that 1.6 when new guidelines come out in the fall, but if they have hypertriglyceridemia, then based on the Reduce-It trial and some of the recommendations and societies that you saw Dr. Goldenberg present, you might recommend something like IPE. And in the case where they have both an LDL that's still above target, and of course a triglyceride that's also in the range that we included in the Reduce-It trial, well, you might consider both an additional LDL reducing strategy, but also an IPE reducing strategy. But it's obviously very complicated, and since Ron already touched on this, we'll obviously go through it, as I can see that there were lots of questions that came in while I was speaking. But when you're actually considering a patient like Carl, it's very complicated, and you obviously, as a clinician, will have to individualize what is most important to you in the cardiovascular risk reduction world, but in engaging the patient in a shared care model, trying to find out what strategy might be most of benefit for Carl. So in his case, obviously you can reiterate the benefits of LDL lowering, and most recently, the benefits of IPE lowering in the Reduce-It trial. You may also want to talk to him about some of the benefits that we're seeing with diabetes therapies, since as you've seen, since 2008, we've had a slew of cardiovascular outcome trials, and SGLT2 inhibitors and GLP-1 receptor agonists have also demonstrated cardiovascular, heart failure, and renal benefits, depending on the background information of the patient. And as Dr. Goldenberg also mentioned, this wouldn't be applicable to anybody we presented, but if you do have that polyvascular patient, well, not only are you considering diabetes therapies, and not only are you considering triglyceride therapy or IPE, but remember that our cardiology colleagues are still educating many of us on the benefits of anticoagulants, and it's not mentioned here, but even double antiplatelet therapy as maybe another avenue for reducing some of that residual risk in our polyvascular patients. One of my final slides, this is what's currently approved for Vasipa or IPE to be used 4 grams per day, typically 2 of the 1 gram clear capsules that you would see that are usually recommended to be taken with food. And yeah, as mentioned, they should be swallowed whole. So to summarize, before we get into some of the questions, as I'm sure there will be many, we can obviously understand now that there are many factors besides that silver bullet of LDL that's been talked about in the pathogenesis of cardiovascular disease. Triglycerides, while they appear to be independently associated with a higher residual risk of cardiovascular disease, and that we now can see in the Reduce-It trial that Icosapent Ethyl was also indicated to reduce the cardiovascular risk, and that this was actually independent of its effect on triglycerides, there are still a lot of questions that remain as to the exact mechanism and the exact pathophysiology, but certainly the data would speak to a very beneficial molecule in a high-risk group of patients. And as mentioned in the last few slides, certainly individualizing therapy becomes equally important. I'll stop right there and obviously pass it back to Peter in the pathogenesis. I did forget to mention one clear thing, and I was trying to stress that in the sub-analysis, but something that has come up a lot in exploring the Reduce-It trial when you compare it to something like the JELIS trial is that a lot of what we're talking about is the fasting triglyceride value. And many are wondering if this might be a similar discussion to what we've seen in diabetes, which is that we both know that fasting hyperglycemia and postprandial hyperglycemia tend to translate into cardiovascular risk, but postprandial hyperglycemia has always been seen to be a greater risk factor. So maybe we're looking at the wrong silver bullet here. Maybe we should be looking at people's non-fasting triglycerides as being an independent risk factor. And when I asked this to Dr. Hegley myself, he told me that unfortunately, while he agrees, there's no standardized way to do that. We don't have any fat meal test or OGTT for fat, but they are obviously exploring whether it's fasting or non-fasting triglycerides that might have at least some explanation in the pathogenesis. But enough for me. I'll pass it back to Peter. Thanks, everyone.
Great. Thanks very much, Alex, for doing that. I think the two talks dovetailed quite nicely together. You covered some areas that Ron hadn't covered, but there was a nice overlap as well to emphasize some of the key important findings. So we have a whole bunch of questions in the chat box. There was one actual request for you, Alex, to put up the IPE benefit slide. So if you could flash that up, you actually had many slides. So anyway, the IPE slide that summarized the benefits, that might be helpful. The first question is coming about a case. So 67-year-old lady, hypertensive and primary biliary cirrhosis, also alcoholic fatty liver disease. Triglycerides are between 3.6 and 17.9. LDL is less than 2. On Crestor or rosuvastatin 10 milligrams and on a fenofibrate. And the question is, would adding in IPE be useful in this particular case? So the issues here are alcoholic liver disease, triglycerides that are off the wall. Didn't talk about whether the alcoholism is down. But what are your thoughts about adding? They've already on statin therapy, 10 milligrams of rosuva and a fenofibrate as well together.
Do you want me to take that one?
Yeah, either one. Goes to both of you. Either one you can take a stab, and then maybe Ron can jump in. Alex, you start.
Yeah. So the easy answer is, and usually I use the triglycerides as more of an excuse to have the conversation about IPE more than anything else. For me, at least, I'll start with some of the background characteristics of that patient. And usually, like I do with diabetes, I would typically at least try to implement a lifestyle strategy. My dog, right on schedule, everyone. Thanks. But usually I would recommend that they at least change their diet, reduce their alcohol consumption, maybe work with a dietitian or one of our CDEs, repeat the triglycerides, and then consider something like IPE.
Okay, and if they're not on a fenofibrate, would you consider? So I'll toss that to Ron as well. So Ron, can you jump in as well?
No, I agree. I just remind everybody that one of the reasons you treat severe hypertriglyceridemia, especially over 10, is to prevent pancreatitis. And so traditionally we recommend obviously diet, alcohol cessation, and fibrates have been the traditional therapy. The patient described was not the reduce-it type patient, right? To remind you, get into reduce-it, you have to have either cardiovascular disease or diabetes with another risk factor. Do I think Icosapent ethyl will prevent cardiovascular disease in other patients? Sure, I think anybody at risk of cardiovascular disease probably would benefit from Icosapent ethyl, but those were not the patients studied in the Reduce-It trial. However, for hypertriglyceridemia, if you're already on a fibrate, then I think it would make sense, even though it's off-label, to consider adding Icosapent ethyl, because then you're adding another triglyceride-lowering intervention. But for the alcoholic patient, the most important thing is to get off alcohol. That'll lower the triglycerides dramatically.
Right. Okay, and then a couple of questions. We always like to get to the fringe. You know, you present us data here, but we always want to talk about what about the edges. So for example, let's say not high triglycerides. Can you give Icosapent ethyl to just reduce risk? In other words, you've shown us some data that says it's really not about the triglyceride, whether you achieve target, not achieve target, high people, low people. And you mentioned that it's the EPA levels that are going up. So I think there's some confusion. People are saying, well, yeah, shouldn't I just take it for the EPA boost?
It's a great question. And so when they first designed the Reduce-It trial, they chose patients with high triglycerides because this drug was already approved in the United States as a triglyceride lowering drug. And then they wanted to show, well, if you give this approved triglyceride lowering drug, does it further reduce cardiovascular events? So obviously they wanted to enroll people with high triglycerides because that was the clinical question. as it turns out, to many surprise somewhat, is that probably the benefit is not via lowering triglycerides. So would this drug provide a cardiovascular benefit to patients at cardiovascular risk, but with triglycerides less than 1.5? Well, the answer is probably yes, but we don't have any clinical trial data to support that statement. And the other thing, I'll just remind you that if your triglycerides are less than 1.5 and you have a good LDL, you're going to be at probably lower cardiovascular risk than the patient who has the higher triglycerides. So then it becomes, what will be the absolute benefit and the number needed to treat in a patient with lower triglycerides? We don't know the answer. And basically, evidence-based medicine suggests now, and the product Monograph supports this, is that we should give Icosapent ethyl for patients with cardiovascular disease or diabetes with another risk factor and triglycerides at least 1.5 or higher.
Okay. There was a question here.
It's worth mentioning, sorry, not to belabor the point, but only people with a certain triglyceride threshold were included into the Reduce-It trial. And I know what, everybody's kind of thinking here, that, well, we waited so long for people with primary prevention to get a good explanation for how they actually derived a benefit from statin. We get it that it's from plaque, and we reduce plaque reduction, and that's why in your high-risk primary prevention patient we see a benefit from statins. We don't have as good an understanding of how exactly that's working with IPE. So while it'd be nice to make certain conclusions, and while obviously Ron and I can give you our opinion, the data is lacking here compared to what you would see in your traditional lipid-lowering cascade, if you will.
Right. We have a, yeah, go ahead, Ron.
So I'll just add two more comments. One, the number of patients in your practice with cardiovascular disease or diabetes with a risk factor with triglycerides over 1.5 is huge. So it's probably like 40% of such patients will meet those criteria. So there's a lot of patients out there that already meet the labeled criteria for prescribing Icosapent ethyl. But for those, just building on that story, what about the patient with triglycerides less than 1.5? So there's a small cohort of patients in Reduce-It that actually did get randomized with triglycerides less than 1.5. The reason for that is when they came in for screening, they entered the trial with triglycerides over 1.5, but then by the time they got randomized, which is a couple weeks later, that triglycerides fell. So there were a small group of people, like 10% or so of the patients, who had triglycerides between 0.9 and 1.5. And they had the same benefit with this therapy. Now, the numbers are kind of small, and I'm not going to say we can extrapolate that to huge populations with triglycerides less than 1.5, but that kind of piece of information does support that this drug will work in patients with triglycerides less than 1.5.
Right. There's one question from a very concerned physician. Does that mean that we have to stop alcohol? So for marginally high triglyceride diabetes, I'm not sure if they're talking about themselves or a patient, but the thought is that if the triglyceride is high, should we be stopping alcohol first? Should we be adding Vasipa? Like, what should we do for the alcohol recommendation specifically?
Well, I don't think you necessarily have to completely abstain from alcohol, but for those that drink excessively, reducing alcohol is probably the most important intervention to lower your triglyceride.
Great.
It boils down to conversation with the patient. No, sorry, I don't want to get into it, but it comes down to the conversation with the patient. If they're obviously less inclined to take meds, make lifestyle changes, then you go that route. If they've made the changes or have attempted them in the past, they'll still benefit from IPE. If they can do both together, more of your patients will obviously achieve the benefits that you're having. You're seeing the same paradigm with diabetes when you're discussing with that A1C of 7.5%, whether they should go on metformin or whether they should try lifestyle changes first. Similar kind of paradigm to triglycerides and alcohol.
Right.
And again, just remember that often those patients have triglycerides over 10, and those are the patients we're trying to prevent pancreatitis in. And so that's kind of different than the modest hypertriglyceridemic patient that they put in the Reduce-It trial.
Okay, great. There was a question about dosing. You know, it's 2 grams twice a day used in the study. What about 1 gram twice a day? Is there anything floating around at a lower dose?
No, the study was done with 2 grams BID. We don't know if there's like a dose response for cardiovascular benefit. And so if you're prescribing this drug for cardiovascular benefit, you should give it at 2 grams BID, which is the approved dose for the indication that we discussed.
Okay, great. Shellfish allergy. So in other words, where does this stuff come from? So IPE it's a purified form, but is it purified from some natural source? Where does it come from? Is there a risk of shellfish allergy or allergies in general?
So this product was basically produced by Amarin Pharmaceuticals in the United States. It is derived from fish, but through a patented process, which is rather stringent and complex, they purify the EPA derived from fish. If you're allergic to fish or seafood, would you be allergic to Vasipa? The actual answer is we don't know because there's not enough data on that, and the product monograph says use with caution in those with known fish or seafood allergy. I would say if your patient gets anaphylaxis from fish, I would be very afraid to prescribe this agent. If they just had kind of a sensitivity or GI problems from fish, then maybe you could try using this product. But the product monograph says because there's really not a lot of data, just use it with caution. But obviously, clinical judgment is very important in those situations.
There's been a couple of questions about cost and coverage. Well, coverage probably not going to happen anytime soon, right? The government doesn't usually cover anything. But in terms of private coverage and in terms of cost per patient, roughly what's the ballpark figure we can tell our patients?
So Alex, you want me to answer that or you want to answer?
Well, we have somebody actually on the line from HLS who's obviously volunteered to answer that. So Graham?
I can give you my answer, and then basically my understanding the cost is $294 per month, but there's a very generous card program that maybe our HLS colleagues. So there's this patient support program where usually the out-of-pocket costs is something like $40 per month instead of $294 per month. But yeah, maybe our HLS colleagues can explain that program, and also how can your clinicians on the line get the access to those cards either in their office or maybe even electronically through their HLS representative. That would be worth commenting, but from HLS.
Varsha, could you unmute their microphone? They might not be able to unmute.
Yeah, he's already on.
Great.
Great.
Hi, can you hear me?
Yeah, we can hear you.
Okay, great. Thanks, Dr. Abbott-Ball and Dr. Goldenberg. Yes, as Dr. Goldenberg said, the price of Vasipa is $294 per month. However, we do have a generous assistance program, the card program. So this is available for patients with any form of private insurance. So they will pay anywhere from $0 to $45 per month. So they'll take their STI card, they'll register it online, or if they are not tech savvy or do not have a computer, they can call a 1-800 number, a concierge for assistance. Then they wait 2 hours. Then they go to any pharmacy to fill it. So if you are interested in receiving some of these cards, we do have electronic and physical cards as well. If you could just please leave your email in the chat, and then we'll have the appropriate representative follow up with you. So thanks, and I'll turn it back to Drs. Abbott-Ball, Lynn, and Goldenberg.
Great, thanks
For
very
those
much
a bit
for that
more
information.
reluctant to share their email with Peter Lynn, you can also send it privately to Graham directly.
That's right. I'll
Just
spam
kidding.
you all
Peter
the time.
has all of your emails.
I know who you are and where you're sitting. Okay, so another question from Philippe. High triglycerides, there was talk that means that they have small, dense LDL and their HDL tends to be lower. There's a whole fancy mechanistic thing to it. Does Vasipa or IPE, does it interfere in that, or is that one of the mechanism, or is that completely separate?
So small hypertriglyceridemia is associated with a whole slew of pathophysiological lipid changes that would accelerate atherosclerosis. And Alex kind of touched on some of them. And one of them, as your triglycerides rise, you're more likely to get smaller, denser LDL particles. That is a particle that is more readily oxidized, more readily enters the atherosclerotic plaque and is associated with atherosclerosis. So any drug or intervention that lowers triglycerides will lessen atherosclerosis as well, by many mechanisms, one of which could be the small, dense LDL. Interesting thing about EPA is that the impact on cardiovascular events really doesn't seem to be related to a lot of those things that we think are caused by triglycerides, because EPA has a lot of other effects, anti-inflammatory, plaque stability, etc., that we talked about. So triglycerides are only part of the story. And I don't think of Vascepa as a drug that's causing the benefit by lowering the triglycerides. I think it is a drug who has a major benefit, and we recognize the high-risk patient who benefits, who happens to have high triglycerides, even though the benefit doesn't seem to be by lowering their triglycerides.
Okay. And then this question, I think, is on people's minds. LDL triglyceride, is one more important than the other? Is there a pecking order? I'm guessing that you guys are going to say LDL target first, statin, and then triglyceride. Are we going to start doing both at the same time? What's your thoughts on LDL, triglyceride? Which one's more important? Do we attack both at the same time? What do you think?
That one, you got to go with the evidence. And right now, we haven't done any, LDL not a target high-risk cardiovascular patient who would be randomized to just triglyceride lowering. I don't think they'll ever do that trial. It would be really considered unethical. For me, I think, like Ron will obviously echo, you got to go with the data that we have today, and that's LDL reduction first. And then you look at either further LDL reduction, like you would with Easytrol or PCSK9, and obviously triglyceride lowering in that carefully selected patient.
Yeah, I mean, I agree. We've had basically 30 years now of the statin era since the first statin was approved in the late 80s. So, and we just have overwhelming evidence that these high-risk patients have to be on a statin plus or minus ezetimibe, now plus or minus PCSK9 inhibitor to optimize the LDL. But along the way, if your triglycerides are elevated, I think you should have a pretty low threshold to add in Vascepa into the mix.
Okay, that's good. And I think that answers one of the doctors that was typing about that specific case. You know, do I add ezetimibe? Do I add these things? So in other words, take care of the LDL, which we know that's a good story that we've developed over the last 30 years. We now have a very excellent story to add on top of that, which is tackling the triglyceride story, which we kind of, sort of left for a long time because, as you showed, we didn't really have very effective treatments in there. Another question here about ApoC3 blockers. In other words, anything in the future that's coming, or are we sort of maxed out currently, and this is where we are? And the future, how far future is that? Are we talking 5 years from now, in which case we should focus in on the current therapies that we have?
That's a pretty smart question. I mean, ApoC3 is one of the regulators of triglyceride metabolism via lipoprotein lipase. And in the pipeline, there are ApoC3 inhibitors, probably a number of years before they're possibly approved or in the clinic, but something to maybe look for in the future.
Okay, great.
We didn't show it on this slide, but yeah, it would definitely be something along a similar promoter like you're seeing. Yeah, it didn't come out. Oh, right here. It's through this mechanism right over here.
That's okay. When it comes out, LMC will have another meeting and you'll explain it to us nicely at that time with these slides as well. Okay, so we'll keep you informed. Ron, can you just go over the risk of atrial fibrillation again with IPE? So I think you sort of said there was a significance, but then you gave some percentages.
So it was about 3% of people on Icosapent Ethyl had adjudicated atrial fib, and it was about 2% on placebo. So there was an absolute 1% increase, probably not very clinically important, except, if you have a patient who has a history of known previous atrial fibrillation, maybe you would be a little more cautious, not contraindicated or not recommended in those patients, but maybe you would watch them a little closer, keep in mind, besides the nuisance symptoms of atrial fibrillation, the big concern is stroke. But the people on Icosapent ethyl had less stroke. And so I'm really not too concerned about a hard outcome and in a problem with bad hard outcomes. If they get atrial fibrillation, it would be more just controlling their rate or trying to convert them to sinus rhythm, whatever. But a small increase, and it's in the product monograph and something we should be aware
of. One question about the HDL. So very low HDL of 0.7. LDL and triglycerides are normal. So in that situation, normal triglyceride, normal LDL, I'm assuming it's primary prevention because they didn't mention anything. So is there anything that we could do for the HDL? I guess that's the question that people have.
So raising HDL has been disappointing as far as reducing cardiovascular risk with various agents over the years. So for that patient, if they have a pretty great LDL and triglycerides are optimal and they don't have coronary artery disease, and probably we wouldn't recommend a pharmacotherapy to raise their HDL, but the usual things like Alex said, exercise, weight loss may be of benefit.
Okay, great.
You'd probably make an argument in the opposite situation. Somebody with a low HDL would be very, very important to consider LDL reduction and triglyceride lowering if they weren't a target. But Ron already touched on the other case.
Here's an interesting question. We're starting to see more of this. So sort of chemotherapy-induced cardiomyopathies. So we're now seeing younger people with all sorts of different cancers. Is there anything out there in terms of this class of medication or statins or anything that we should be doing to help lower those people's risk? Anything out there that you guys have seen? And there might not be much because that field is developing right now.
I'm not aware of anything, but it's a good question.
Okay, all right. So
it comes like from internal medicine training, and from memory of the Royal College exams. But you would generally just treat them as your typical cardiomyopathy patient. So you give them the usual cardiomyopathy cocktail of beta blockers, statins, and ACE and ARBs, but no aspirin since they don't have coronary disease. You'd have to kind of ask yourself here, if you're thinking that it's more along the atherosclerotic process that they would benefit, maybe there isn't a role for something like this. Statin with a well-established role is indicated mostly because you don't want a second hit like ischemic cardiomyopathy on top of another form of cardiomyopathy. But even I'm getting a little bit far from the Royal College exam, so I'd have to look into that question.
Yes, but there are meetings coming up on the oncology side and cardiology, so that's a good area that we should be looking into. Let's see, aspirin and rivaroxaban and has atrial fibrillation. Is it safe to use IPE on top of that? And I think that's the question relating to bleeding risk. So you were mentioning that if they were on other agents, that there was a slight increased bleeding risk. So would that be of some concern?
It's not a contraindication or not recommended. There is perhaps a slight increased bleeding risk, as I showed you, like 13% versus 11%, give or take. Again, you got to use clinical judgment. If you think your patient has many risk factors for bleeding, you might be more cautious. You could even ask why that person would be on aspirin plus rivaroxaban. But in the trial, they had patients on various antithrombotic combinations, and it really wasn't a big issue, but there is that signal of a little bit more bleeding, but again, not fatal bleeding, not very serious bleeding like CNS or GI bleeding. A lot of these things were minor bleeding issues, but again, you can give it, but just be aware and be a little more cautious.
Yeah. And then
you might want to clarify what dose of rivaroxaban you're using here, because as Ron mentioned, it'd be pretty rare that you get somebody on anticoagulant doses of rivaroxaban also on aspirin. But if this is a COMPASS patient who's just on aspirin and low-dose rivaroxaban, the risks of bleeding with low-dose rivaroxaban are not as comparable as high-dose. So maybe more dependent on the specifics here, but completely agree with Ron. And obviously, let's get through the chat questions, Peter. I think there's still 1 or 2 people with their hand up when we have a chance.
So we've got Dr. Dawson, if we can unmute his line.
Varsha?
Varsha, if you could do that, that'd be great. If not, there was one quick question here about LMC and pre-diabetes education. So they said, if we have time, could you just mention how that works? Because I think last time Dr. Bajaj had mentioned something about a program or something like that. So if you want to just briefly talk about pre-diabetes or this counseling that you guys have at LMC.
Well, thank you for that question. I swear whoever just asked that question, it was not a planned question, but this being the 5th webinar of the summer, I, of course, was ready with the Canadian Pre-Diabetes Prevention Program, as it has come up during every single webinar. Firstly, for those wanting to refer their patients to LMC to take benefit of the certified diabetes educators or an endocrinologist's opinion for pre-diabetes, we're more than happy to do it. This is what most people are, of course, asking us about, which is the collaboration between Diabetes Canada, LMC Healthcare, and the Public Health Agency of Canada, which is a program for your patients with pre-diabetes that benefits from obviously lifestyle and behavioral coaching. Totally free of charge. You can see the inclusion criteria on the screen. It's a 12-month program, all digital, and you can see at the bottom the 5 different ways that you can refer your patients. I'd encourage everybody to just go to the LMC website, because you'll find lots of information about the diabetes prevention program there. That's all I have to say about that, so I'll pass it back to Peter.
Great. So Dr. Dawson, if you'd like to ask your question, your microphone is unmuted.
Hi. First, is this accredited by the College of Family Practice?
You will get the certificate and the credits, yes.
Okay, great. I don't have to register it, or?
No, they'll send you the certificate, and then you can put in the credits into the website underneath your name at the college.
Okay, and the second thing is I want to get the
If you open up the chat, you can download the certificate as well. If you're on your phone, feel free to email us, or you'll see the information about the certificate to put on the college website on the last slide coming up. Go ahead. Sorry, I meant to start.
I couldn't make the chats work. The other thing is, can you send me the cards so that it's $40 a month?
Yes. So just send an email back in. That'd be fine. Yes. And your question is?
And the last thing. This is a silly question, but I just sent a guy with a blood sugar of 33 to Emerge today.
Yes.
What are they going to do with them?
So blood sugar of 30. So on the diabetes topic, super high sugars, they go into hospital. What do you guys do with them?
So you can't just decide about treating somebody based on sugar level. It depends on their clinical status. Are they sick, whatever? Because if they're acutely ill, you want to rule out ketoacidosis or a hyperosmolar non-ketotic state, an infection, whatever. If they're pretty well and they just maybe have some polyuria, polydipsia, they're not in ketoacidosis or in a hyperosmolar emergency state, often we can manage these people as an outpatient, and we'll get them into our clinic quickly, sometimes started on insulin as an outpatient rather than being admitted. But again, just the number alone is not enough information for us to decide. But if the patient's acutely ill with lots of signs and symptoms, usually they end up being admitted to hospital.
All right, that's great. So what I'm going to do is, first of all, thank you both for an excellent presentation of taking us through the data and then how does it apply to our patient. I'll just go quickly through a summary. For those that need to log off, please log off, just click on that certificate. But I'll just quickly go through. Ron told us this beautiful sort of 26-year history, starting from statin therapy to ACE inhibitors to dual antiplatelet to SGLT2, GLP-1, aspirin and a NOAC, and then now IPE. And those are the things that are changing our practice. He nicely went through a case with Brenda that was real, and then talked about is there a triglyceride increased risk, and then told us some Canadian data that says triglycerides over 1.5, there's increased risk. And then the question is, can you reduce that risk by reducing the triglycerides? Sadly, phenofibrates couldn't do it. Niacin wasn't really helpful in terms of bumping up the HDL. Omega-3, it was sort of mishmash of stuff, and it was because these are mixtures that we're using. So we know that the EPA portion of it is good. The DHA may not be so good. And so therefore mixtures may not be helpful. And that's why the studies weren't able to show a benefit. And so therefore, if you now have a purified version of EPA, which is IPE, then in the REDUCE-IT study, you saw that the patients were on statin therapy, either with established heart disease or with diabetes and one risk factor. So that would be pure primary prevention. And their triglycerides were over that 1.5, 1.7 range. You could see that there was nice benefit. And it was 4 grams per day, taken as 2 capsules in the morning and 2 tablets or 2 Vasipas at nighttime or with dinner. And the results was a 25% reduction. For those that like absolute numbers, 4.8% absolute risk reduction. Number needed to treat is 21 over 4.9 years. And the p-value was a lot of zeros, which means that if you did this trial 100 million times, you would get the same result. So therefore, probably not a fluke. Whether you're primary prevention, secondary prevention, there was benefit. Whether you were high triglyceride, low triglyceride, you had benefit. And whether you had diabetes or no diabetes, there was benefit as well. And it didn't matter what your triglyceride you achieved, you still had benefit. And so it was the EPA levels, I guess, that was high, that was actually of some benefit for our patients. And if you look at the subgroups of what about cardiovascular death by itself, or MI by itself, or stroke by itself, or heart failure, any of those parameters that you looked at, there was benefit. And so therefore, overall, good benefit. What is the downside? A small increased bleeding risk of about 11.8% versus 9.9%. So you're talking about 2% difference. So out of 100 patients, if you treated 100 patients, there would be 2 people difference in terms of bleed. In terms of atrial fibrillation, the risk was 3.1% versus 2.1%. So if you treated 100 people, there would be 1 extra atrial fibrillation person. And I don't think you and I will be treating 100 people, so we should be okay. Then showed us nicely the ADA guidelines have now recommended, almost based on the study itself. So if you have diabetes and atherosclerotic disease and you're on statin therapy already, and if your triglycerides are between that range of 1.5 to 5.6, then they're recommending you add an IPE on top of that. They're saying don't use statin and fenofibrate and don't use statin and niacin together because their studies didn't come out well. European guidelines, very similar, but they're moving towards just the high-risk population. So therefore expanding it a little bit. And then they talked about specifically IPE being a purified version is not the same as everything else that's out there. And you saw very nice slides describing that as well. And so now we look at LDL cholesterol. We know that we can improve that risk by ezetimibe and PCSK9 inhibitor. You can now look at triglyceride risk. And if you're over that 1.5 and you fit the profile, then basically an IPE is a good option. And we know about GLP-1 and SGLT2 for your glucose control. And we also know about the dual clots using aspirin and a NOAC or dual antiplatelet therapy is helpful. And then perhaps in the future, the inflammatory process, we might introduce that as well. And then in terms of Alex, he told us about Carl, which was a primary prevention patient. So no event yet. And of course, he didn't do anything and then he became a secondary prevention patient. So hopefully we can prevent a lot of Carls from moving forward by treating all this residual risk. And then nicely took us through the primary prevention program in terms of the breakdown of the study, that whether you're primary prevention or secondary prevention, there was no difference between the 2 groups. So statistically, there was no difference. And so therefore, they're behaving similarly together. And then he nicely showed us about the timeline. So if you had diabetes for 15 years or more, then your cardiovascular risk of having that first heart attack is as high as somebody that's had a heart attack without diabetes. So therefore, your risk of getting that first heart attack is high just based on the years that you've had diabetes. So perhaps as primary prevention, we should think more about it for our patients with diabetes that are longer duration for sure. And then in terms of triglyceride metabolism, he didn't cause us too much pain. He went through some pretty slides looking at that, talking about the ApoB being on all the particles that are delivering cholesterol and triglycerides, and on the ApoA is on all the particles that are moving away and the garbage truck. So therefore ApoA only exists in terms of your HDL particles. And then talked about lipoprotein lipase, which kind of transfers triglycerides back and forth, and how if there's a defect there, there may be some issues in terms of cardiovascular events. And if it's working very well, then you might actually have cardiovascular benefit. And then he pointed out that the triglyceride curve in terms of events, it flattens out. So therefore, it's not like LDL where it's nice and linear. And so that's why we haven't had a lot of talk about it, because as you go out in the higher triglycerides, your event rates don't seem to go up. And then because we're giving mixtures of things, we weren't able to show the benefit until the GELIS trial, which was using a much higher purity of EPA. And there was a hint that maybe the EPA portion is good. And then, of course, going through the IMPROVE-IT study with a very pure version of it, you can now see the benefit. And so nicely, he concluded that maybe we should be looking at not just secondary prevention patients, but also many of our primary prevention patients that have diabetes and one risk factor. And if you think about your office, the bulk of your patients you and I see on a daily basis is that population, because they're the frequent flyers. And we'd like to make sure that they don't become a secondary prevention patient, because he also showed you that if you have diabetes and you have an event, your risk now becomes extremely high of having another event coming forward. So the goal of all of this thing is to continue to reduce risk. And so nicely, I think both presentations covered many different aspects of reducing risk. And now we have this extra layer of triglycerides that we can add on top, that we can reduce risk even further. So on that note, I want to thank you personally for all of you guys joining in and hanging in there, for Alex for putting together this whole program for us, and for Ron and his encyclopedic brain, but that was very understandable, and for HLS for sponsoring this particular meeting and doing all the trials to make sure that we can actually bring some benefit to our patients. And I'll turn things back over to Alex Abitbol to finish up the meeting.
Can't conclude any better than that. I want to thank everybody for attending. I want to thank Dr. Lin and Dr. Goldenberg. I would do any event with you guys any day of the week, anytime, any place, whether it be virtual or in person. Peter already thanked HLS, and obviously we couldn't have programs like this that we could obviously deliver for free without their generous support. I don't have to talk about the Canadian Prediabetes Prevention Program because it's already done. As alluded to, this is the session ID that you'll want to enter on the CFBC website to get your credits. Varsha has already nicely also made it a PDF that's downloadable. We welcome all of your feedback, as this meeting is a result of the direct feedback we got in June. That's all I have to say. Have a great evening, everyone, and I look forward to seeing everybody again in November.